Okay, so it's a pleasure to be here, and thank you for this amazing organization. It's really a pleasure to be back here. The first time I was here in Democritus was to learn more about nuclear physics when I was 16, and I used to live like a couple of kilometers in Agia Paraskevi here, so it feels like coming back home. I'm going to talk about, I just want to take a disclaimer that I am not an AI expert. I am an end user, so I'm crashing the party. But I definitely know a lot about imaging, and medical imaging. And I'm going to talk about the medical imaging perspective and how we use AI to make the most out of the data. And also I'm going to use some of the great work of some of my colleagues, some of whom are also new members at HIAS. So I basically have my lab at Columbia University, where some of you have also visited. It basically has a couple of campuses. One is the engineering campus that I'm showing you here. On the left, if that rings a bell, this is the Law Library, which is based on Rome's Pantheon, so that's probably more familiar. On the right is part of the engineering school, which is all research based. And that's not where my lab is. My lab is on the medical center, and the medical center is a very dense area, like a lot of things in Manhattan, but this one is full of different hospitals. This is a very old hospital, and not old when it comes to Europe, but very old when it comes to the US. They say the oldest hospital in the US. So this is the Presbyterian Hospital, and my lab is in the 19th floor. So we really are benefiting a lot by the community around us, which is several hospitals, several doctors, several different specialties, and we pretty much collaborate with at least 10 different departments, clinical departments. So as I said, I'm going to focus a lot on medical imaging, and my expertise is on ultrasound imaging. So we make images like this one. Some of you students here may have gotten your first picture as an ultrasound image, so we really love these images, very cute images. But we don't use these images much. Okay? It makes parents happy, but we don't use them. So what we want to understand is more about diseases, and I'm going to spend the next 45 minutes on some of the main diseases that are actually we need to solve pretty fast, which are also affecting people around us and family members, friends, and sometimes ourselves. And we have a big problem that we need to solve. So we see how images, what imaging can do right now and what AI can do further. So I'm going to start with breast cancer and then moved on to Alzheimer's disease, then heart disease, and then hypertension and stroke for the end. They don't need, I think, any introduction at this point. I'm going to show you some statistics and why we care about these diseases later. So breast cancer definitely doesn't need an introduction. I'm just going to actually give you also a medical perspective and also an imaging perspective, and then go to the AI part, because I'm really a believer that you need to know where your images are coming from. And a lot of the AI community has no idea where these images come from and why, and how variable they can be according to the different scanners and all that stuff. Breast cancer, we know, is still the second cause of death for women, especially under the age of 65. And then it's the highest cancer, most prevalent cancer in women. I think this is the US, but I think it's also global. The imaging modalities, mammography or mastography in Greek, it's basically the most prevalent. It's currently administered on all women annually above the age of 45. I'm not sure exactly what happens in Greece, but that's how we do it in the US. It has very good, pretty good specificity, not much sensitivity, but this is the best we can do right now. And it doesn't work very well in women with high breast density. I'm going to talk about MRI in a second. That usually substitutes that. It has this horrible positioning in the breast that I'm not going to talk about, and then also it involves radiation, so you can't do it on a regular basis. MRI is a great modality that offers a lot of resolution. I'm going to say that also in AI, in imaging, it definitely dominates, and that's because it has this magnificent signal-to-noise ratio, contrast-to-noise ratio, and resolution. And I would say about 90% of the papers that you see on AI and imaging are based on MRI. Very few in ultrasound, unfortunately, and I can talk about that later. But basically, it has to do with how good quality images and how consistent the images are. There are some limitations, however. It's costly. It cannot always be used on patients with pacemakers, other post-surgical clips. Or pregnant women for that matter, and it can be very time-consuming on the order of hours. So ultrasound also is used quite a bit, especially when it comes to women that have dense breasts. It has also high specificity, but also low sensitivity. So some of our radiologists actually prefer to use MRI instead of ultrasound, which I'm not happy about, but this is basically what it's being done right now. The opposite of MRI is very low cost, portable, and opposite from CT and mammography. Doesn't involve radiation, ionizing radiation. But it is very limited to how it's used, and we're trying to solve this problem here as engineers for a long time. I have my Fulbright right now in the medical school in Paris, and we talk about how we can potentially replace this hand-eye coordination that is needed for doctors and sonographers, which is right now irreplaceable. So this is the palpated lesions. Palpated is when you actually can feel it. This is what is applied a lot by physicians and also by patients themselves. They typically feel the lump on the breasts, and then they actually, if mammography hasn't caught it, they catch it that way. And then whether you catch it with mammography or with palpation, then you have to undergo a biopsy. And that's actually something I'm going to talk about a little bit more about how we can replace potentially biopsies with AI and imaging. And the reason why we want to replace biopsies is that most of the time they're benign, which is great news for the patient, but you have spent time and also effort and also pain to the patient because it does involve getting a piece out of the tumor and involving needles and all that information and all that procedure, which can be very painful. And of course, the cost of understanding this. So this is, I'm going to talk about the work by Despina Kondos, who used to be at the University of Pennsylvania and has worked extensively with breast cancer AI, and she recently has moved to Columbia, so we're very happy about that. And I'll talk about a center at the end of this first part of the talk, where we're trying to basically merge a lot of different imaging modalities with what we can do from biopsy. And it involves, the center involves image analysis, pattern recognition, and data mining. So we can actually use, these are mammograms up here, and I think she's also showing an image here, a Doppler image. And the idea is to do all three, screening and prevention, so that's really what saves most of the time lives in breast cancer. And when I talk about Alzheimer's, this is basically what we're missing. We're missing the big screening and prevention that breast cancer has. Then prognosis, so whether there's a recurrence or metastasis of the tumor after diagnosis, and of course treatment. I'm going to talk a little bit about how we can inform treatment using imaging and potentially also using AI for automation. So how can we merge MRI or imaging modalities such as CT and mammography together with what we know from biopsy, for example. So a biopsy will give you a histology or an image of what the tumor cells look under a microscope, and there's a lot of work done there in how you use histology and macroscope images with AI. I'm not talking about this today, and I'm sorry if somebody came here for this talk to see what we can do with histopathology images. That involves yet another talk, not by me, but somebody who is actually an expert. But the idea is to actually use these are lung images, brain images, and also breast images that are alternating here. This is actually a cancer phenomics toolkit that was built by Christos Davatzika's lab at the University of Pennsylvania. I'm going to show some of his work in Alzheimer's, where they actually have an open source, an easy-to-use toolkit, and then they have also these QR codes where you can actually use them for as the open source. And then you can load the images that you have and be able to understand more of the underlying cancer prognosis. So this is a coined term of radiomics back in 2012. So the idea is to use radiology or images, medical images, together with transcriptomics, proteomics, and a way to understand the proteins that are actually involved in the cancer, the mutations in the cancer genome, and also some of the RNA that we can actually do that. So it gets very biological and very medical very fast. So these people have actually been able to bridge the two. And the idea is to also use the networks, neural networks, to be able to train based on existing data where you have paired the images of the MRI or CT or ultrasound, for that matter, of the breast, and also what the biopsy actually showed, and then use new data to actually potentially get closer to what the biopsy will show or doesn't have to show, because you can replace it with the images themselves. So some of the features that are very important, and I already talked about breast density for prognosis. Breast density, I mentioned that it's an issue when you actually have a mammogram that needs to be performed because it does have a breast that looks very opaque. So that means it doesn't allow the X-rays to actually penetrate and look at the actual underlying tissue. So it looks very white. And this is actually what you see here, very white regions of very high density, very difficult to tell the tumor as a result. Unfortunately, these are also the breasts that have been shown to correlate with breast cancer. So we have a challenge here where you actually have a challenge for the imaging, but at the same time, these women that actually come with dense breasts and potentially may have a higher probability of cancer. We don't know exactly why it correlates, whether this is a correlation or causation, but there's a lot of literature on that to understand that better. But we do see a pattern here of what's called the parenchymal pattern. That's actually the actual tissue, and it has a pattern specifically that you can link to underlying tissue volumes, and then you can also do, this is an MRI image where you can do also 3D rendering of the underlying breast. And then what you can do is actually use this parenchymal, what we call phenotype. So phenotype is phenotypos versus genotype, genotypos. So this is how you have something that looks like it will be cancer and then link it back to its underlying gene analysis. So the way that is done is basically looking at this high dimensional features such as density, but they also call them, you can also do a histogram and understand more of the other features such as co-occurrence with the tumor itself, the dense region. And then you have a cancer risk assessment that then you can also use in lungs, such as for centrilobular emphysema. And then finally, look at the underlying genetic signature of the cancer, the disease at hand. And when you combine the two, you can calibrate it with these radiomic phenotypes and be able to have a better validation across where the actual potential reoccurrence of the cancer could be. So the idea was to have the breast parenchymal texture patterns to predict a better who is actually may develop breast cancer later on. As we know, mammography is done annually for the women above 45. So the idea is to, what they're doing here is to actually have a texture analysis by overlaying a lattice. So like a grid, and then be able to inform the underlying texture, then have this multi-channel CNN that they can train with these images, and then they've shown that when you do the texture with the multi-channel CNN, you have excellent predictive analysis or area under the curve, where you can use it as a predictive tool compared to texture alone, which has been done over decades in MRI, so trying to get the texture of the breast, or just the CNN single channel alone. Then going back to the prognostic assessment, what other features could actually be used? So then here is when they're looking at the gene expression, the segment. I don't know if we can lower the lights a little bit, because unfortunately these images, I think, are too dark. So basically they do the tissue staining. This is actually the histopathological image that shows you the gene expression, and then you match it with some of the features from the mammography here. And then you have these imaging markers that you can separate according to the time to peak. In this case, they inject gadolinium, which is a contrast-enhanced region that goes into the tumor, and as you can see, enhances it as a result because of its vasculature. So now, instead of looking at the breast density, you're also looking at the feature of perfusion. And angiogenesis is a form of looking at how active the actual tumor is, and it also facilitates segmentation. I think this was done automatically. And then as the gadolinium goes into the tumor and peaks at a specific amplitude at a specific time, you can actually separate it according to the amount of perfusion volume that went in and also time to peak. So then you can also make images like this one, which shows you the tumor heterogeneity. So the more heterogeneous the tumor, the more difficult to treat. And in fact, there are different potentially chemotherapy agents that would treat different regions, but we're very far from understanding how this heterogeneity could be targeted with different chemotherapy agents. Thank you very much. So they've used here multi-resolution wavelets to be able to look at the kinetics of the underlying contrast agent, and they've seen how heterogeneous the tumor can be. So this is the outline of the tumor. You can see some regions are less perfused than others. Red is more perfusion than others. And then they've used also some other resolution levels to actually tap into the heterogeneity. So then when they did all that, and also they used positron emission tomography with another tracer. This is another scanning modality that I didn't talk about. It's not actually very common, I think, in Greece, but there's some PET centers in the US, I think about 40 PET centers. So this is a molecular imaging modality that allows you to actually link to some of the molecular signatures of the tumor. And they're able to get this spatial temporal heterogeneity, and then after segmentation, match it with some of the markers on the FDG PET, on the contrast PET, and be able to predict that this four-dimensional heterogeneity, so 4D means a three-dimensional tumor, and also the perfusion over time, is allowing to predict recurrence in tumors. And this is some of the areas that they actually have been able to see as a radiomic biomarkers. Some statistics here that they published a couple of years back. Similar work, Despina is also working on, as I mentioned, lungs, so that she can do the same radiomic application on lung tumors, and this is one of the lung tumors that is segmented here, and she was able to link that to one of the most common mutations in lung tumors, but also in tumors in general, that you only know when you have, when you do an analysis of the tumor. It's called the EGFR, and she was able to see that with this non-invasive radiomic phenotyping, NSCLC, she was able to get a better predictive ability based on that mutation. And then going back to the radiomic, but in this case having the genomic phenotyping. This is some of the work that both Christos Tavadzikis and Despina Kontas have published more recently based on the toolkit that I just presented earlier. And they're able to actually identify some of the EGFR mutations and then link it to all the expressions here of radiomic genetic features. So what you see here in different colors are color-coded according to the number of mutations, what kind of therapy stage this patient was at, the gender, and some of other aspects. And they were able to get excellent receiver-operator characteristics as a result of merging these modalities together with, in phenotype, together with existing data on patients that have been undergoing liquid biopsy. That can enhance the prediction of response to the treatment. So liquid biopsy is something, I'm not sure if it's applied here in Europe, but it's something that you use as a blood test in the US to be able to detect whether there's any circulating cancer cells. And it's called liquid biopsy because instead of sampling sampling the tissue, I was talking about the breast, you actually sample the blood. So the liquid is the blood, and then you're able to basically detect some cell-free DNA and sometimes also some proteins that the tumors are excreting in the blood, and they can do the biopsy without getting a direct sample from the tumor. So to conclude this first part of what Despina is doing in breast cancer, she's integrating this imaging, clinical factors, histopathology, as I mentioned, and also some molecular markers in this multi-parametric model approach, and towards personalized screening, prognosis, and treatment of breast cancer, but also lung cancer. And this is the center that I mentioned that we are starting this fall. We're launching this with some $10 million investment that Despina was able to find with the Dean of Medical School and be able to combine medical center experts, engineering, some public health experts, cancer center, and be able to use all the biomarkers and tap into the resources that are in this such a rich medical center, from imaging and also histopathology, but also markers. I want to, before I get to the next topic, I want to talk about a little bit of what we can do more functionally and from the aspect of ultrasound imaging. My work is more on imaging the functional aspects of the tumor, and this is, we call it technique harmonic motion imaging, where we're able to vibrate tumors from afar and then be able to have a map of the tumor. And also do some ablation that I'm going to show at the end. So very briefly, just showing you where these images come from. We perturb the tissue and we're able to identify where the actual tumor is. And then from there, we actually performing a clinical study where we have our scanner. It looks very engineering because it is. It's not a clinical scanner. It's an open architecture scanner where it allows us to get the data from within the breast. And then we have a clinical study where we're trying to basically see at which stage we can tell where the chemotherapy works. I'm going to go really fast here. I'm just going to show you a couple of images that are based on palpation and mention that you can do a self-examination, or even the actual physician can actually find the breast through self-examination. What we're doing here is combining the ultrasound of the breast, and this is where the tumor is. Actually, see it here. And you can't see it very well here, but with these actually images of the relative stiffness, so blue means stiff, so you would feel it as having basically a small golf ball in the breast, and we're able to actually make maps of what you would feel inside the tissue. But the most important thing is to actually follow it during chemotherapy, and this is where we have this patient started chemotherapy at this point, and then 2 or 3 weeks later, we scanned her again, and then at the end of the treatment. And what you see here is that this tumor is very resistant to chemo. So you can actually, you don't need AI to actually see that. I'm sorry about that. You can use human intelligence for that, but I'll show you some aspects that AI can help with. And sure enough, this patient unfortunately was not had a non-pathologic complete response. That's not good news. That means that she probably has to either continue the treatment or change the drug treatment. But we had also patients that responded, and they have complete pathologic response. This is such a patient. You see, this is the images that we make in color, and this is the ultrasound image. And what we have as a biomarker is called displacement ratio. So that means how did the ratio of the displacement compare to the tumor and the surrounding tissue change? And in this case, it went up. That's what you want. You want it to become softer. So the tumor becomes softer as a response to within a couple of weeks. A very good sign. And then at the end of the treatment, you can see also by color that the actual tumor became extremely soft. Okay, this is, and also when the patient was actually operated on a few weeks later, sure enough, she had a complete pathological response. Excellent news for that. But going beyond that, what we found is that we have much better contrast. I mentioned earlier that it's all about the images that you use. And if the images that you use to feed the network are not good quality, it's not going to work as well. So what we said is, okay, so we can see the tumor better because we have this mechanical contrast, again, that you feel from palpation. Can we use that information in a better way than a standard B mode? So B mode is a standard ultrasound image that is in grayscale. And in fact, in this case, this is an image of a phantom. So that's in imaging, it's called phantom because it's the ghost of the patient. So you test your images on something that looks like a patient, but it's not a patient. And you can see that we have actually here a tumor or simulated tumor that you cannot see because it has exactly the same echogenicity properties as a surrounding medium. But when you have this harmonic motion image, you're able to see it because of the change in stiffness. So we said, okay, so if we wanted to segment this image, even with AI, it will be impossible. So what if we feed it these right images, and we call this HMI net? Very important tasks in cancer and also in the rest of the imaging world is segmentation, and actually most of the AI approaches are spent in segmentation. So we borrowed from some really smart people who have used the transformer multimodality. It's called the MM-former, and then we had a channel attention mechanism to do cross-channel learning, and then hybrid loss so that we are able to see how well we actually came to the ground truth. And I'll show you the ground truth. Oh, I'm showing you the ground truth here. I know it looks like, what is she actually segmenting? Well, this is when, and somebody's talking about this later, I think, this is when our brain does better than AI right now. And I know this image is not something that you're familiar with, but somebody who has a trained eye as a radiologist can trace where the tumor is. So this was a ground truth, so we did all this encoder, decoder, probability map, binary mask, and then we finally saw how well we were doing feeding these images, including the actual ultrasound, compared to the ground truth. So we use a trained validation set, a test data set from the phantom that I mentioned earlier that I showed you. We also had a cancer model, a breast, a tumor mouse model. We also use ablation as a therapy, ultrasound ablation that we're also working on. And then finally, a human breast tumor, which was malignant. So we saw that when we were feeding these images, both the ultrasound images and the harmonic motion images, the stiffness images, if you will, we were having a good dye score, and even at very small tumors of about 2.5 millimeters, we had a 0.88 dye score. Of course, it was getting better with the bigger tumors. And the ground truth that I mentioned earlier was actually matched pretty well as a result. We did much better in earlier than later stages, but overall during the progression of the tumor, there was a good agreement. And then the clinical studies as well. This is a patient where the actual ultrasound was used for the ground truth, and then the predicted boundary was actually sometimes not as well done, but then after 3 weeks of treatment, at the end of the treatment, we found that we were actually much better in segmenting. Compared to the phantom, the mouse studies, the patient studies had the highest noise and estimation error, but overall the network worked really well with a low bias. The last thing I want to show before I move on to the next topic is that we also can follow how a lesion, a thermal lesion is actually formed. So this is a lesion that you can form with ultrasound ablation. This is used not in Greece, I know that for sure, but it's used for treatment of the brain for essential tremors. And we aim to, and for prostate cancer, and we aim to use it for breast cancer, where you can actually ablate or burn a lesion in the breast, and so that the patient doesn't have to undergo surgery. That can be done very easily for benign tumors. So the challenge of this lesioning of treatment is that you cannot see it on a regular ultrasound image. And you know, you see a brightness here, but it doesn't always correspond to the image. And sure enough, when we actually see the stiffening of the lesion as we're forming it, the network performs a really good job at understanding where the actual lesion is. So we're very happy about this, and we've done this during treatment. So as you are depositing thermal energy and you're creating a burn inside the actual tissue, we're able to actually see not only where the lesion is forming, but how big it is after a couple of minutes of treatment. Okay. Okay, so the second topic is about Alzheimer's disease, and I promise it's going to be shorter. But it is not as, unfortunately, well diagnosed as breast cancer. And it's not alone. Unfortunately, Alzheimer's plagues the brain together with a lot of other neurodegenerative diseases, and I'm not going to talk about, but whatever I talk about today, I think it also has applications in Parkinson's, for example, ALS and Huntington's, which are less common. So Alzheimer's disease is basically characterized by two proteins that we still don't know whether they're the cause or the effect after a century of research, and that's how slow sometimes biology is, unlike some engineering disciplines. But basically, we know that amyloid plaques, amyloid beta, are spreading around the brain from a region of the brain that's called the hippocampus and the entorhinal cortex. And then at the later stages, the whole brain is full of amyloid. So these are the stages pretty much that where unfortunately the disease right now with the drugs that are available is unsalvageable. The one region where we could potentially save it is at the stage A. The early Alzheimer's. But as I mentioned, diagnosis and screening, unlike in breast cancer, extremely difficult right now. But it would be great for AI to do something about that. And then obviously there's another also aspect. It's not just amyloid beta, it's also tau, there's another protein. So amyloid beta is actually formed in different parts of the neuron and between neurons, and is not allowing the communication between neurons. Tau is actually inside the cell and has a lot of different elements. Now, we all have amyloid and tau in our brains, by the way, and it's a good thing. But this is an accumulation that's abnormal, especially with hyperphosphorylated tau that goes in this, what we call tangles. So what can deep learning do here? And I'm going to show a couple of papers that came out of Christos Davatzikos' lab at University of Pennsylvania. One of them was recently on looking at how the dimensional representations of Alzheimer's disease are manifested on the MRI and on the structural MRI. And he used generative modeling here for the disease effects. And that was one of the highly regularized scans that wanted to basically see, based on normal, healthy individuals, how you can actually identify where the brain is actually potentially of a patient has a different different structural features on the MRI. So he used different transformations and clustering in the latent space, I think that was mentioned in the previous talk, and identified specific disease subtypes, or what he called dimensions. And then the regularizers were that he found was inverse consistency, sparsity, monotonicity, and some other regularizers that actually effectively helped with the clustering. And then when he put it all together through a predictor, and he used two latent space dimensions, R1 and R2, and then some other variables, and also a machine learning predictor together here with the tau, amyloid, and some other cognition, memory cognition markers that are known from these patients. He was able to actually get a 95% confidence interval of potentially evaluating treatment and having a more personalized patient management. And then he went a step further and was able to actually use a lot more of these dimensions, upwards to 5, but I think later on he has even more than that. And then according to the statistic was able to actually see how they varied across the entire brain. And then according to where in the brain it was and what kind of feature, whether it was an atrophy, subcortical or cortical, or some in a specific region that was correlated with specific diseases, as well as other comorbidities such as smoking and alcohol consumption. He was able to use those in the surreal GAN model that he called, and then with multidimensional clustering, he was able to actually see that in 50,000, in about 50,000 individuals, he could actually prognose some of the both death from disease, but also progression of disease. And that was summarized further in that paper that I showed earlier, but then they used what's called this gene scan, where they actually were able to, in this case, discover some subtypes of disease through this genetic and imaging signatures, and through this weakly supervised deep clustering. And this is a visual of what they did here. I'm not going to attempt to describe every single part of it, but they blended some phenotypic features based on what they showed in the previous paper, some genetic features, and then through the GAN, were able to infer some of the latent variables, and then afterwards they were actually able to combine the GAN and the VI, variational inference, to be able to predict some of the imaging genetic data and how it could identify some of the disease phenotypes. Okay, so third, how much time do I have? 10 minutes, okay, I can do it. So the most deadly diseases in 5 minutes each. So heart disease, okay, so this is something that we would like to actually use one day as an imaging, but this is from an artist that was able to show how the heart is contracting at every heartbeat. And then it's also our hearts are electrically activated at every heartbeat. We have a natural pacemaker here, and then you have the coronary arteries that are lining the outside of the muscle, making sure that we have oxygenated blood at each heartbeat that allows the muscle to contract and relax. So that's what this beautiful animation does. Hopefully one day we can do it in all of us, and we have images like that of our heart. We cannot right now. And then this is the coronary arteries, where most of the heart disease lies, and then causes problems, occlusions, and then compromises the muscle underneath. But we also have a lot more vessels that this is known after post-mortem, ex vivo. Unfortunately, we cannot do this in vivo. Maybe one day. There's some groups that are actually working on that. And you're able to see the smaller vessels. So CT, computer tomography, does an excellent job of looking at, with contrast, on these big vessels. But if you have a smaller occlusion in what's called macrovascular disease, it's impossible due to the resolution to see it. So that can be a magnificent AI medical problem that I think nobody's working on right now. Most people work here. So, as I mentioned, it's a number one killer, at least in the US. It's a silent killer. It's the heart, like a lot of other organs, compensates for it. I'm going to talk about the other two here, carotid artery hypertension, in the next section. And this is what we can do right now with ultrasound. And I'm not going to talk about MRI because I don't think it's used extensively for cardiac. But from the functional aspect, something that CT doesn't have, is that we can actually see all the 4 chambers in the heart in real time, and that's the advantage of the echo. You can use it with, as I mentioned, similar to breast cancer with ultrasound. You have a handheld probe. Then you turn it around and the segmentation right now, it's something that's failing with AI. I'm not going to talk about the failures of AI, I promise. So, but it's very difficult, and now we have to basically do a manual segmentation of the left ventricle, which is the most muscular part of the heart, and also the right ventricle, map the two, and then we're able to, I'm going to talk about how we can do electromechanical activation. So before I talk about electrical activation, I'm going to talk about mechanical activation. This is a healthy heart. So red means thickening or high strain, and blue means thinning, which is the opposite of what you want during systole. We have been working on this technique called myocardial elastography for a long time, and we have been able to differentiate somewhat between normals and ischemia or scar at different coronary territories, as they're called, in the left anterior, distal, left circumflex, or right area of the heart. And then more recently, we used the KNN ensemble subspace model, and we were very happy with that because we increased our NDR area under the curve to 0.9 with a very high sensitivity compared to a regular echo and specificity. And then the variables that we used was not just the actual motion or strain or deformation. We also used in the model other comorbidities that we found that we can get that way, AUC, the area under the curve of 0.9. And when we looked at the correlation matrix of why this worked, we had 2 things pop up. Right? One was that the radial strain was actually correlated very well with coronary artery disease. So the fact that the amount of deformation, according to the KNN, that was actually inwards into the lumen, so as the heart was contracting radially, that will tell you more about how well perfused it is and if there are clots. But the other interesting aspect is a circumferential strain correlated very well with the suspected smaller microvascular disease. The smaller vessels that I showed you were correlated with how well the heart is doing deformation along the circumference. So both these strains we're actually looking at very closely about differentiating between macrovascular and large vascular disease. I'm going to skip this for the sake of time. Can I take a couple more minutes very fast, about arrhythmia? That's less known in imaging because there's no imaging modality that can show you what you see in an illustration, again, artistic illustration here. You can see the ECG, so electrocardiogram, that is very well depicting areas of the atria, the top of the heart, and also the ventricles, the bottom of the heart. And you can see that in this particular case, I mentioned the pacemaker that we all have at the top of our hearts that works very well. Sometimes it doesn't work as well, and it causes this vortex inside the atrium. So right now, the only way we can see it is through the irregularity that you see or additional frequencies inside the electrocardiogram. I'm going to skip this part and tell you that we are developing ways to look at, based on a regular echocardiogram that shows you these 4 chambers that I mentioned earlier. On top of that, you're going to see a blue wave that propagates from the top to the bottom, and that shows you the activation of the heart. Now, how we do it, I don't have time to talk about it, but what I can talk about is what we can do with automating it. So I'm going to skip that. I'm sorry that I have to skip this. But it all depends on the zero crossing. So basically the heart is undergoing this positive strain during diastole, where it's pushing the blood out. And then a negative strain during systole. So when it switches from positive to negative, this is a zero crossing, and it has a couple of zero crossing, whether you're going from diastole to systole or systole to diastole. And right now, we're doing everything manually in the previous maps that I showed you. And we want to automate it. So we basically had a lot of feature collection that we measured based on the slope, on how many zero crossings, and some other maximum, minimum strain. And then we fed it, we had a stable zero crossing when we actually see one zero crossing as opposed to two, which was the candidates. And we used these different features and data labeling with the other candidates. We used precision recall as evaluation metrics. And then we used, I know this is very basic, but we used logistic regression, SVM, and random forest. And when we looked at all three, we were able to see that after evaluation of human validation test, we had the SVM work less well than the random forest. And then with both the recall and the accuracy. And then when we tested it on compared to the manual zero crossings that we had, we were able to see that the random forest again predicted the map of the electrical activation much better than the logistic regression or the SVM. We have used it in other aspects as well. Again, the random forest is what we are currently working the most with. And one of the reasons is that because we want to drop the frame rate. I didn't have time to talk about the fact that we have very fast frame rates. We're trying to sample the heart as it beats. So we have thousands frames a second that we use with our customized ultrasound scanner. But however, clinical scanners can only offer you upwards to 100 hertz as opposed to thousands of hertz. So we wanted to compare whether there's anything that we can salvage in activation compared to the ground truth that we have here as the baseline after manual selection. And it turns out that we are giving away some of the quality, but we can actually overall see that the septum, the muscle that separates the two ventricles, activates first, followed by the two ventricles. So we're continuing that with more data into the network, into the classifier, I'm sorry, to be able to feed it with thousands of frame rate maps and also get potentially this into the clinic. I promise I'm going to talk about hypertension and stroke. 2 minutes? What, 5? Oh, great. Thank you. Because I was going to suffer from my own hypertension. Okay, I already showed this particular slide, and I mentioned coronary artery disease as a silent killer. Unfortunately, we have a couple of more. And they're all affecting vessels, by the way. Vessels are extremely important in the body. I mentioned the coronary artery, but we also have the carotid up here, and that feeds our brain. Very important that we have an open carotid or patent carotid, and if it gets occluded, then that potentially leads to stroke. That means further occlusion inside the brain, causing a lot of debilitation, and it's the third leading cause of death and the first leading cause of disability worldwide. And it's not just this carotid, by the way, that feeds the brain. We have a lot of other vessels, and this carotid carotid occlusion accounts for 25% of strokes. And then we also have hypertension. 1 in 3 subjects suffers from hypertension and hopefully take their medication. But it's also a precursor to heart disease, renal disease, atherosclerosis that I mentioned affects these blood vessels up here, aneurysms, and then all this probability increases by up to 4 times. Oops, something's happening. Okay. It's under control? Okay, HIAS got that. Okay, good. Okay, so, oops. All right, so I'm going to talk very briefly about the work that's being done in Spireta Golomati's lab at the University of Athens. So she takes regular ultrasound scans that are from the carotid in subjects that have been suspected to potentially have a stroke, and she uses asynchronous motion of this plaque here, that the segmentation is done manually in this case, as I mentioned, very difficult to do in an ultrasound image, and then looks at the radial and longitudinal plaque motion. So what they've seen is that a vulnerable plaque, so that means a plaque that has more lipid, is actually having this asynchronous motion. So she's trying to automate that, and you can see that when you have a regular plaque that doesn't have this asynchronicity, is all red. And then because you're mapping the motion on top of the contour, here they have much more blue, because instead of all going up, some of it is actually rocking back and forth. And she has used these features from 135 plaques in 77 subjects, and found that the radial deformations, and again the deformation towards the center of the blood vessel, is synchronized by approximately 50% with the arterial diameter. And then she looked at the phase shifts between these two regions, and she found that with the random forest classification, with all these features, she was able to see upwards to 0.9 area under the curve based on the stenosis risk and the stenosis degree and the plaque risk. So that's also only where you have the wall itself. So ultrasound also has the flow, and that's actually used a lot inside in the actual most hospital centers, where you actually see the flow at the same time as the wall. And in my group, we're trying to combine them and also be able to track the wave that propagates as a result from the carotid to the brain. So we call this pulse wave imaging. It's similar to the pulse that you feel if you press on the carotid on the side of your throat. You will feel your pulse, and then we're tracking it along the wall. So the wall is segmented here, again manually, and then the lumen is where the flow is, and you can map also the flow at the same time as the pulse. So when we combine the two, we can feed it into what we call the pulse wave inverse problem, where you actually can get the pressure. So obviously we know that the cuff pressure is how we measure blood pressure, but most of the information that we need is actually in the central part of the thorax, and that's because that's what the heart is experiencing. It's not really experiencing this pressure, it's experiencing the pressure from the system here. And that's very difficult right now to get pressure from central blood pressure, as it's called. Another big field that I don't have, unfortunately, time to talk about, but we are using a physics-informed neural network, or PIN, and we're working with Petros to make it faster, where you feed it all this information in 3 dimensions and in time, and then with a specific loss function, you're able to represent some of the, both the aspects of the flow dynamics and the solid mechanics, and be able to get the pulse pressure in the lumen. So we have done both the neural network for the inverse problem to get both the compliance, so how stiff the arteries are, and the underlying intraluminal pressure. And we're solving these equations here with the unknown parameters being the compliance and the pressure. And then also the same equations here with the finite difference method, and then we compare it to what the actual neural network is having as a solution. And when we compare, I'm going to skip that. I'm sorry. When we compare the two, we find that we have. Oops, wrong one. We compare the two, we find that we have a very good agreement between what we find with the inverse problem and the simulation itself, so high correlation and low bias. And then when we compare the PIN to what we actually had with the simulation, the finite difference, we also find excellent correlation, both for the pressure in pascals here, but also with the compliance. So this is my last slide. Okay, only breast cancer is in red, but I hope I showed you that we can do excellent breast cancer radiomics for prediction of disease progression, mainly using MRI and PET images, and I've shown you a little bit on the lung cancer as well. We're also aiding in tumor segmentation ultrasound images based on the underlying stiffness. In Alzheimer's, Jesus Tavadzikos' lab has shown that you can do prediction of survival from Alzheimer's and also identify genetic signatures that can predict with generational AI whether we can actually see better the progression. On heart disease, we've used convolutional networks to get more of understanding of how the heart function is affected by coronary artery disease and macrovascular disease, and then we can automate the detection of zero crossing on activation and a cycle length that I didn't have the time to talk about, and potentially put this in the clinic for high frame with low frame rate imaging. The last thing is that the PIN networks could help on the inverse problem to get the actual elasticity of the vessel and also the underlying pulse pressure in the central circulation. I want to thank the groups that have given me their slides for this presentation, some of our funding, and also my group. Thank you.
Thank you very much for a wonderful presentation.